Thank you, everyone. Hi, I'm Ceci. I am just really thrilled to be here today. I haven't been part of a conference like this where I feel like you can really put a string from the first person who spoke today all the way through. There are so many connections in everything that we do. So I'm really just thrilled to be here. I'm going to check to make sure that I know how to move things forward. Dr. Cannison was very gracious for the introduction. And really, my goal today is really to talk about some of the ethical considerations, really focused on equity, regulatory, and other considerations. And I'll discuss briefly the National Academy of Medicine framework on health care and innovation and equity. They actually released some guidelines based on working groups that they've had for a while, but they just released them about a week and a half ago. So when we talk about ethics, I think this exhaustive list here, so many of our speakers have actually already touched on a lot of these things. And I'm going to really focus this on a few things, like I said, equity, regulatory, and just a few other considerations. But why equity? And I think as most people in this room, if you're really involved in quality improvement or safety, this work is health equity work. So several years ago, I wrote a paper on the ethics of big data and artificial intelligence. And one of the things that I found just so interesting was one of the reviewers asked, why can't a white man code for the entire world as long as there is representative data? And I found that really interesting for a lot of different reasons. And really, I took that as a challenge of, I am not really expressing what I want to express in the correct way. I am not reaching the audience that I want to reach. So why does representation matter? Well, I don't care if it is a white man, an Asian man, a trans man, or a Black woman. You are leaving out a vast proportion of the population when one phenotype is really looking at the data. Now, I am very honored to be a physician scientist, and I saw this documentary, and my bias when I saw this, picture a scientist. What comes to your head? And I can tell you, rarely, even in my own lab, am I mistaken for a physician scientist. And I just find it really interesting when you look at the world and you look at the experiences people have. When you look at anesthesiologists or healthcare providers in general, so much of how we manage or we treat our patients is based on our experience. So representation matters for many different reasons. I love this example from Joy from MIT. She's a data scientist. And she was working on something completely unrelated. She is a Black woman physician scientist. And she found by accident, really, that facial recognition did not work for her skin tone and her gender. And so she did an experiment, and she looked at a lot of facial recognition systems out there. And by and large, dark women were misidentified at much greater proportions than white men. So what does that have to do with medicine? And in June, I met Alina James, who is doing some incredible work, and her presentation was on visual learning. She's a dermatologist, and she found that she found that there is a problem, that there is an underrepresentation of dark skin pictures in education material for our medical students or nursing students across the board. and she found that this is a problem. And really the only high representation of dark skin tend to be for very socially stigmatized things like infectious diseases. Then you're much more likely to find pictures in medicine, in education, in our textbooks that we're all learning from. And again, why does that matter? Because it actually matters in the type of work that we're doing on a day-to-day basis. So one of the post-COVID things that we have found is that it came to light that things as simple as the pulse oximeter that we use every day to make decisions in anesthesiology, in the ICU, in the floor, for remote monitoring, for all of these things, they tend to perform less well in dark skin. And again, why does that matter? Because one, patient safety, that should be enough. But if that is not enough, then thinking about now that we know what legal implications do we carry as safety ambassadors. So this paper out of JAMA really went through and talked about kind of what are the legal implications of this. If we know that pulse oximeter isn't working as well, and we don't check oxygen saturation, blood oxygen saturation for dark skin colors, could that put us at risk for legal implications? For patients to be able to sue us or sue the hospital for not having adequate monitoring for our patients. There's also a proposed change to Health and Human Services rules that specifically prohibits covered entities from using discriminatory clinical algorithms in healthcare decision-making. So again, I think that this speaks again to a lot of the work that we're doing here, both as providers, as inventors, as patients. And so really a lot of work now has been done to try to mitigate some of these issues. People are kind of seeing it in a different light. And this is some work really out of our department in collaboration with some data scientists, where they're specifically trying to tackle this issue head on. And I think that is part of representation and why representation matters. All right, so we talked about representation, and part of representation is bias. Unconscious bias, which again, I think Michael talked a little bit about and we've talked about in different areas. I'm not sure how many people notice that this is actually in Spanish, but this is in Spanish. We tend to have a lot of language bias, which is part of my work that I do. So again, years ago, we talked about what are some of the biases that we have to really think about from an ethical standpoint. So is AI, our machine learning programs or algorithms fair? And what is fair? That is a very, very, very big question. But what implicit or explicit bias is being integrated into these algorithms? How is the training data representative of our target population? Again, we could go on, but really, what is an algorithm? So take a little a Crayola here, and so we have an input, a set of rules, and we have an output, and that is an algorithm. And how are they made? By humans. And we all have biases. I have biases. Every person in this room has biases, whether they're conscious or unconscious. And these are built by our set of experiences. I can't tell you how often, I'm a new graduate. I have not been faculty for very long, but I can tell you that every time I worked with a different attending, they had their own rules of how I was supposed to do my job. You never do this. You always do that. And what built those experiences was their past experiences. What they have learned, they are now teaching me. And that is how algorithms are made. Whether they're conscious or unconscious, you are pushing forward your sets of experiences. And I am positive that my life experiences and how I see the world and how I interact with the world is very different than each and every one of you. And I don't think that most people who are doing this type of work are trying to be racist. I don't think people are trying to cause harm. It is the unintended consequences of not realizing that there are vastly different views of how we interact with healthcare. So I think that these examples here are just incredible. One, looking at how using an algorithm on resource allocation. So these data scientists created an algorithm. They take patient information and they decide these patients are sicker based on how much money they spent, how many hospital encounters, how many things are they doing. So now we're going to create an algorithm and we're going to put it out and we're going to roll it out and help us to decide who is going to receive higher level of care. Not realizing that underserved communities may not have the money, may not have the insurance, may not have the trust to go to the hospitals as frequently. So expenditure is not equated to health. So when you roll out the system, Black patients who were of equal health to white patients had less resources allocated to them. And that's because this algorithm was created by someone who didn't realize that maybe people who are disadvantaged are not spending as much money on healthcare, not because they're not sick, but maybe because they don't have the resources or they don't have the trust of the institution, they don't have insurance, they're not able to make it to regular doctor's appointments for a whole host of reasons. And when you think about this and you think about health disparities, equity really needs to be at the cornerstone of innovation to improve access. I don't think machine learning, AI, is this terrible thing that we should all run away from. I think quite the opposite. We need to adopt it in a way that improves access. When you make equity the cornerstone of your development, of your algorithms, of your institutions, of your care paradigms, that's how we are going to take a very flawed system and improve access and equity to care across the board. So we need to learn how to be proactive instead of reactive. When we look at historical data and you say, well, the data doesn't lie. We're just taking the data and we're applying algorithm to the data. If the healthcare system is flawed, the data is flawed. And if you don't think about it from that perspective, you may have very good intentions and introduce irreparable harm to your patients. Whether it's language access, people with disability, race, cultural norms, other social determinants of health, if by bringing in people with vastly different experiences, you're going to be able to tackle some of these issues in a way maybe that you would have never thought about yourself, but bringing in a multidisciplinary team with multiple people in various areas, you're able to tackle this. And I'm going to share a recent story actually with a colleague of mine. Not in my department, but we're both applying for grants, and we have similar language equity work in different fields. She was hired in, she's a PhD, and she received a mandate by a director of a center, said, you need to bring me your people. I can't recruit your people. How are you going to bring me your people so that we can have representative data? That is part of the problem. If you can't hire a research assistant and expect that is going to change the way data is collected, data is inputted, data is annotated. That does not solve the problem. It may be the first step of actually having some representation for some clinical trials or different things, but when you say, bring me your people, that's a problem. And if that doesn't get to you, if equity just on its own doesn't get to you, there is a huge return of investment. When you look at the data across different companies, different sites, if you have a diverse workforce, you have a much higher return on investment. So for hospital systems, for companies, think about putting equity in your cornerstone to improve the bottom line. From a regulatory standpoint, these are things that we have been talking about for well over a decade, whether it's privacy, data security, data ownership, data stewardship, governance. It's really something that people have now started to, the lay people have started to really see this coming to the forefront. It's at their conscience about consent, for example, or what harm is done to people. Again, I think that we could all have very good reasons for wanting to do certain things, and we think about data as a whole and not necessarily always as an individual, or vice versa. We only think about it as an individual and not necessarily as a whole. But you can have patient privacy issues, whether it's leaked data, but when you start to aggregate data and you think of unintended consequences. So what happens when prediction models say that this person is going to be sicker and actually insurance companies will drop a patient when there's no safeguards for patients who are going to become sick. And we've heard of stories in the news where Google or Facebook or somebody knows that you're pregnant before you do because things are changing. You haven't gotten your period and it's on your tracking device and it's on your iWatch and everything is integrated. All of this data is out there. And when you start to aggregate this data together, it really isn't de-identified anymore. And the regulatory systems that we tend to think about is HIPAA. But there is such a vast amount of data that's out there that goes beyond hospital data that is not protected. So really we're at this cross-section between the ethics, innovation, and legal standpoints of who owns the data, who gets data, how do we share data, how do we access data. And there are a lot of different implications about how we collate, aggregate, and use the data, whether it's Epic, whether it's MPOG, whether it's your own at your own institution. We have to think about more from a regulatory standpoint what safeguards we're going to be putting in place. And really accountability. I mean, we've talked about transparency, but I think that this goes beyond transparency. We talk about the pulse oximeter and how does it work. I can tell you that many people use a pulse oximeter every single day and they have no idea how it actually works, or any type of monitor. So transparency is one thing to think about, but when we think about judgment, I think Michael was talking about judgment. Who is inputting judgment, does that make you legally accountable for the work that you're doing? So again, another thing to think about. We recently wrote this paper, and it was a really fun paper to write on just ethics of big data and perioperative medicine, but really talking about unregulated AI at the bedside. A lot of companies, a lot of providers spend a lot of time and money into developing decision support tools, developing the pulse oximeter, and that's all great and good. It goes to the FDA, CMS, how do we reimburse? But what happens when ChatGPT is helping your first-year resident make medical decisions about care? And whether you like it or not, that's happening. You can have, it's July, you have your brand new intern who doesn't want to wake up their senior or their attending or their fellow in the middle of the night, and they ask ChatGPT, they do a curbside consult, and to see what they should do. And the reality is they have no idea what ChatGPT is. Again, a colleague of mine who has children was telling me, I was talking to her about this paper that I'm writing. She has two less than 1 year twins, and she asked ChatGPT what she should do about something. And I said, well, do you know what you're asking? Do you know what information? She's like, oh, it even had PubMed IDs. And so I know that the data was real. It's like, oh, you really have no idea what these large language models are and how they work. And very educated people, very smart people, very well-intentioned people just don't always know how to use the technology around them, whether that is an FDA-approved monitor or unregulated AI assist or curbside monitor at the bedside. So education is so important. It needs to be fundamental, not only for young, new trainees or medical students, but for each of us practicing on a day-to-day basis about what we're using and how it impacts the patients that we're working with. There needs to be greater education on data stewardship. We need to have greater education access to each type of device. I just, again, also recently, I had a colleague at a different institution, but a colleague who asked me, you know, can you teach me how to use point of care ultrasound? I need to learn how to do this. And it was to do ultrasound guided A-line. This is also somebody who supervises trainees at another institution to use ultrasound on a day-to-day basis. First, I was shocked that she would ask this because she supervises. But I was also very proud that she recognized that she needed additional learning and would go back and ask on how to use the technology, how to use something that she does actually use on her day-to-day patient care. And so often we have so much ego in what we should know or what expertise we have. It's very difficult for us to show where we are lacking. And this is something that we need to change, the overall culture of how we look at these things, because again, it's not about ourselves, it's about our patients and what we're doing on a day-to-day basis. So whether that is learning about artificial intelligence, big data, the monitors that we're using, or just having a simple conversation with the patient, we need to do better. We need to communicate better. So the National Academy of Medicine, like I said, just over a week ago, published this framework for innovation in health and medicine. There's actually a webinar, I think, that you can get the highlights from. But they really thought about this from a systematic standpoint for such a long time. And so I really encourage you all to go through. These are kind of the bullet points and how they decided to address this. But it is a much larger document and something that I encourage all of you to go through and read. So looking forward, technology will evolve. The solutions that we think of today and the problems that we're thinking about today are not going to be the solutions and the problems of tomorrow. So when we think of these changes, these how we're going to address some of these issues, some of these inequities, I actually think that if we make equitable healthcare at the cornerstone, everything will improve. Not saying everything will be great, but you bring the tide up when you really make this as part of the cornerstone. You need to engage stakeholders. And by engaging, I don't say have your research assistant meet the community that you want to bring in, but actually make partners across disciplines and within the communities, and make true partners that can help you develop your technology, develop your algorithm. You talk to the patients and you try to understand what matters to them. When we think about judgment and what Michael was talking about up here, about that judgment, and is it better to have a stroke or an AKI or pulmonary edema? Why wouldn't the patient be part of that conversation as well? Why wouldn't their family be part of that conversation as well? And absolutely incorporate education. If we do not teach people what we are using and how we are using it, it is never going to get better. And more inequities will 100% be systematically embedded into our healthcare system. Thank you.